Carl and I are going to talk about advocating with evidence, and it's a bit of a bridge between this morning and this afternoon. So this morning was all about the doctors telling us about symptoms and all the science and all of that. And what we are going to try to do is make the bridge to the afternoon. And for that, we need to advocate. We have to be there to show people who we are. Next slide. How do I do that? Yeah, thank you. So this is us. We both work for AGIOS. We both work in several committees there. Well, you see Carl's thing. I don't even gonna go into that. He's a busy man. I think that's the conclusion we can set. The next slide, please. Don't know how. Do I have a button for that? Okay. So you've seen this one before. This is actually the first time pyruvate kinase deficiency was published. So that's 60 years ago. And the data that they had here, but there was Dr. Valentino, it was mentioned this morning. He did it together with Dr. Tanaka and Dr. Miwa. And the way they did this was to collect symptoms. And they went to the science and they wrote their story here up and they published it into the world. And that's great. So next slide. So they were publishing it in medical magazines. They were doing it case study reviews. They would go to conferences and they would talk, and it's been going on like that for years and years and years. And a lot of doctors are very much wanting to share. They are very willing to understand things about PKD. But many of you here do not have doctors that have the interest for PKD. Many of you say, well, actually my doctor, I'm the only one. He's not really interested. He doesn't really know about it, and he doesn't want to connect to other people, which in some cases is very understandable because they have other diseases they care for. I'm very lucky. I go to the hospital in Utrecht, and 20 years ago, I remember very well, I was standing in a kitchen. I got a phone call from Richard van Wijk. Sorry, it's a Dutch name, very difficult for you. But he's a genetic counselor in Utrecht. And he said, you don't know me, but I do know you. You're number 4 on the genetic list of PKD. And I know you. I don't know exactly the number, but he knew sort of the number. And that was amazing to hear someone say, I know you, and I am studying this. And now there is Dr. Eduard van Beers here in Utrecht as well. And he has the same passion. So I am lucky, and I'm very aware of that. And many of you are not. But therefore, we need each other. So next slide. So it's important to come back from the doctors. Historically, it were the doctors. They looked at the science, they looked at the symptoms. But the same doctors, like Eduard van Beers, like Dr. Grace, and many others, they are looking for the connection with all of us. And we've heard this morning, Dr. Grace already mentioning the peak registry and the natural history. But why is it important? Well, we are rare. As we all mentioned this morning, there are so many different genetics differences. So we are rare, and so we can't really expect our doctors to understand and to make the connections as this man in the 60s did. You can't expect every doctor to do that. We have to be our own spokesperson. We have to get out there, as we do here now today as well. And on these registries, as Rachel Grace was talking about, the peak registry, it's not a lot of work. It's really not. It's just you share your information, and they can do so much with it, and they make it broader, and they make the connections, what we need so much. So next slide. Again, I just mentioned information is scarce. Rare disease, it's very scarce. We are all different. I hear so many stories this weekend, and none of them is mine. And I think you had probably the same. Your story is not my story. So we are all completely unique, and therefore these registries need to hear our voices. The symptoms are not always easy to identify. So you might have something, but you don't know if that's PKD. We sometimes say, oh, this is PKD, or maybe it's not. You know, we have to make, again, we make the connections. We have the cultural challenges. What is normal in America is different in Europe. And by having a worldwide or broader registry, we can, again, connect those dots. And we have financial challenges because it's very expensive to every doctor to do this on their own. So if you have a together and we all sign up, we can connect the dots. Next slide, yeah. Well, this was already mentioned in the morning, so I don't need to go over that. Dr. Rachel Grace does a much better job on that than me. So I go to the next one. I would like to go to the future as well, because I'm very cheeky here. I was asked to go talk about this, but I really want to go forward as well, because I would love to see this being a worldwide approach, because we're now very much aiming to Europe, Australia, and we're looking at America, and it would be so good to include more countries, because I'm very sure there are more. I would love to see the developmental challenges, and I'm sure that's already done in the peak registry and also the National History Study. It would be great to see more different cultures, the cultural differences. Americans, I so often talk to Americans and I'm amazed because it's so different. And so we feel different. The nutritional differences. I know your diet is different than my diet, and a vegetarian diet, how does it affect our PKD? It would be lovely to see, again, those connections. And what I'm very, very much keep on talking about is the psychosocial effects, because so many times I hear people talk about their psychological struggles, their social struggles. I cannot get the blood. There is no blood. Cannot afford to get the treatment. There's all these problems, and children who are dealing with people and in hospitals. It's not easy to bring that in as well. And of course, the last one, and it's very relevant for me, unfortunately, aging and PKD. We don't know anything. And I think these studies will bring that together as well. So I will give the word now to Carl, and he will start off with a video, and I'm sure you can manage it. So I will hand you over.
Maaike, could you play the video for me, please, that's embedded? Thank you.
Pyruvate kinase deficiency is a lifelong, rare, and under-recognized hereditary anemia that often presents in childhood. The PEAK Registry is a database where medical information from patients with PK deficiency is collected anonymously and with their consent to help healthcare professionals and researchers better understand how patients are affected by this genetic disorder. This presentation characterizes the baseline demographics and clinical characteristics of patients with PK deficiency enrolled in the PEAK Registry as of March 2020. As of that time, 140 patients had available age data. 60% of them were adults with an overall mean age of 25 years old. According to medical history, almost 76% of the patients with PK deficiency had received blood transfusions in their lifetime. Additionally, patients show a wide range of hemoglobin and ferritin levels, with 2/3 of patients having ferritin above 500 nanograms per milliliter. In summary, the valuable information collected in the PEAK Registry provides important insight into the disease burden associated with PK deficiency and gathers useful information that can be used in assisting healthcare professionals with the clinical management of their patients with PK deficiency. For more information, or if you would like to participate in the PEAK Registry, please visit us at peakregistry.com or email medinfo@agios.com.
Thank you. We'll have the next slide, please. So you'll see this is real life data from the registry, and the PEAK Registry is sponsored by Agios, and it is a descendant, as Rex said earlier on, of the natural history study. Currently, there are just over 200 participants, and it will run for up to 9 years. And it is overseen by a steering committee of expert hematologists and a patient representative, and I'm the patient representative. And I have to say, there is genuine patient engagement. It's a really weird experience. There are about 15 hematologists from around the world, and they sit on Zoom calls and they ask you all the questions and they ask you where to go next. So, for example, we've added in questions around mental health and around cognition. And that was, came from the community. That's the thing we wanted to look at. And from that, you've seen some data there. There have been many abstracts and poster publications, and we've got quite a number going to the American Society of Hematologists this year. And I've been very lucky and honoured that I've actually been able to be the lead author on one of those around the sub-studies that we're doing. So these 2 sub-studies that are underway, one is about the health-related quality of life using patient-reported outcomes. So that's a kind of a long questionnaire that's validated and asks you how you feel about certain aspects of your life, your well-being, etc. And then you can repeat it at different times. And, this is work I do back home, and you can link it up to any treatment changes, etc. So you can have a proper conversation about how you are, because I say to people, you go to the doctor and they say, how do you feel today? Well, I don't know. Is it my heart failure? Is it my thyroid? Is it my blood? Is it whatever? Yeah, you don't understand. But if you've got a proper data set. So there is a sub-study including people from the US, Netherlands, Italy, Spain, and the UK for over 18s, and we're looking for 75 participants. And we're also in the US, Netherlands, and Italy doing a sub-study around the impact of PK deficiency upon cognitive performance, and we want 33 participants for that. So to be part of these sub-studies, you must be enrolled in the PEAK registry, and both of them will be, as we said, we've been reported about what we're doing at the moment through the ASH special conference publication of the journal Blood. Next slide, please. So this data, we're going to share this with you afterwards on air, but this is an abstract that has come out of the registry. And this is all about iron overload by age. And, what we're finding is iron overload and hemoglobin, or number of transfusions rather, they're not linked, So this is really important stuff. So when somebody says you're kind of a transfusion because of your ferritin, actually the evidence now is there isn't necessarily a huge link in terms of, yes, it will push it up, but actually not having blood will also push it up. And another piece of work we've done is looking at comorbidities. So actually what other disease processes happen as a result of PK deficiency. And we know that jaundice, biliary events, cardiac complications, all the things we talk about, we've actually got real world data. And that's the phrase we use all the time now, is real world data. It's not from a test tube or a Petri dish, it's from inside us and it's collected about us. And that is really important that we actually have this proper data. And what this whole talk is about actually is being able to use this data. It's another abstract that's been published in Blood previously. And we want to advocate with this data. So we want to convert this data into usable things that you can take to your hematologists or your local physicians or whoever it is that's looking after you, and very carefully and respectfully say, look, actually, I probably do need an MRI because I haven't had one for 10 years and we don't know what's going on inside my body. So what I'm really, really keen to do is get as many of you or your kids who have PKD enrolled in the PEAK registry. It will help build a picture of your life, what's happening, and what, we can use this data for better care in the future. And we will, if you're part of the registry, then you'll have access to a kind of a site within the registry website, which will come online probably around December this year, maybe a bit beyond. And Brian is very helpfully nodding at me. And actually, at that point, I will introduce Brian, who has become a good friend of mine. You can see him, he's now stood up at the back. And, if you want to enroll, have a conversation, we're going to make it easier for you to enroll. Rather than if you live in the US, it's only in the US, Dr. Rachel Grace has agreed to be a principal investigator for people across the US. So you won't necessarily need a local hematologist or an investigator near you. But you can talk to a hematologist or talk to one of us and we can put you in touch. And there isn't like 10,000, it's not like a drug trial where you have lots of extra bloods and scans, etc. It's about you giving consent. And in the US now, you can do that digitally. The law is allowing that. So you don't necessarily have to travel to Boston. You can have a Zoom call probably with Dr. Grace. And there's a way of doing the consent remotely. And that's all we really need from you at the beginning. And then the team behind will go and ferry off and scuttle off like little fairies and data mine and get all your data together. And it goes into the system. Now, as a patient representative, it is a real honor. And I mean, we've kind of talked about how to advertise this more. But actually, we can influence the registry. And we've been careful about how we've done this through social media because the legislation around what you do and how you advertise things, etc., is quite tricky. But you probably know me by now. And I want you to reach out to me if you've got questions around it. And actually, as time goes on, I want to come to you guys as well and say, what are the next questions you want answered? So at any point, if we then change what I call a questionnaire, it's a completely wrong word, which could be in a number of years' time, but we could influence what other questions go into this maybe. And then we are able to seek data. So Tamara, as you know, is writing a paper about nutrition. It's rather bizarre, but I have a particular interest in end-of-life care, and I'm looking to write a paper around end of life. And where we've got formal kind of clinical questions to answer, we can apply to the registry to have data. So we can't just say, I'm interested in knowing my hemoglobin against the other 250 people in it, but we can say, there's a research question about what happens in children of a certain age. And, after you've had your spleen taken out, can we, is there a change in data as we've seen today? So that data is also out there. So, I say this really carefully because we're going to be respectful of the fact that it is a confidential zone, but actually it's our data. And if we work together, we can bring this data out. And the whole thing is we need to advocate using data. Data is the future of healthcare. We can use patient-reported outcome measures to understand how things impact us internally. We can have a look at blood results. We can look at other scans, etc., and all that data that goes in, which you don't have to do. I think it's a once a year kind of questionnaire that needs to be done by yourselves, and that's all it is. So we have got around, say, 250 people in it now. We're looking for 500 people. And I would really urge any of you in the room who are able to sign yourselves up or sign your kids up, please do so, because it is the future of how we're going to get our own healthcare sorted out. So thank you so much. Thank you for listening, and we'll hand back.